Okay, good afternoon. Now we are more awake because in the previous session all of us was nearly slept, but I think this topic is also very interesting. Not only my lecture, but also the topic of erectile dysfunction. Okay, this is the disclosing slides. Okay, regarding learning objectives of this lecture, I will try to provide the latest update on a step-by-step management of erectile dysfunction. We will try to understand the value of the patient education and shared decision-making process in order to have a better consultation, to understand the differences among the available drugs, to explore all more important treatment options according to realistic patients' expectations, to provide the latest update regarding innovative treatment modalities such as shortwave, PRP or stem cells, and provide practical algorithms that are helpful in daily practice for selecting the right man for the most effective treatment option. Erectile dysfunction, as we know, is defined as the persistent inability to obtain and maintain an erection sufficient to permit satisfactory sexual performance. ED, erectile dysfunction, may affect psychological health and have a significant impact on the quality of life of patients and in their partners. It's commonly classified into three groups based on etiology: organic, psychogenic, and mixed. But actually, the last decade, I suppose, that we understand that there is no pure organic. Maybe it's pure psychogenic, but for somebody that has erectile dysfunction, at the beginning or later on, for sure, a psychogenic component can compound this condition. So we have to have in our mind that independent of the organic origin of erectile dysfunction, every patient maybe needs also a psychogenic evaluation or treatment or whatever we will see later on. It has been suggested to say that it is primary organic or primary psychogenic, meaning that always psychogenic component is present. The majority of men with erectile dysfunction are not treated with cause-specific therapeutic options. We know that all our therapies are not according to etiology, but they are the majority of them according to the symptom. So a tolerate treatment strategy that depends on the invasiveness, the efficacy, the safety, the cost, and of course we have to take consideration the patient's preferences. So it is important the physician and the patient to communicate well in order to establish a shared decision making how to go further on. Okay, the systematic review has shown that consistent discontinuation rate of all available ED treatment options. That means that it is very important, this communicate, as I said before, it's important for the clinician to understand the patient's beliefs about ED treatment, therapeutic ineffectiveness, adverse events, quality of intimate relationships, and treatment costs, all of which were shown that the most prevalent barriers for the treatment use. Sometimes for us it's very easy to say take this pill or whatever consultation we made, but from the patient way of thinking, sometimes they think different. For example, I had a patient that they said, okay, if I take the medication, I'll perform very well, but I don't want to take pills because I believe that this erection is not mine, it's artificial. So I want to highlight that it's important to communicate efficiently with the patient to understand what exactly he is thinking. So educational intervention informing patients about the psychological and physiological processes involved in sexual intercourse. Not all people know about sex. Not all people know, all men know that They need, for example, to get excited. They need that the sexual activity is not obligatory. So it's something that we have also this to have in our consideration. This baseline approach has been shown to favor sexual satisfaction, means all this proper communication. Consultation should include a decision of the expectation of the need of the patient and his sexual partner. It should also review the patient and partner's understanding of erectile dysfunction and the status of diagnostic tests and provide a rationale for treatment selection. Erectile dysfunction may be associated with modifiable or reversible risk factors, including lifestyle or drug-related factors. So, to advise patients to have a different way of living, sometimes is very important. For example, to stop smoking, to exercise a little bit, to lower cholesterol, etc., etc. In the majority of cases can be beneficial. So control of concomitant and underlying related conditions, endocrine disorders, metabolic disorders such as diabetes, and some cardiovascular problems such as hypertension. Lifestyle modifications including physical activity, weight loss, and treatment of cardiovascular disease risk factors, and lipid-lowering therapy with statins may improve sexual function in men with erectile dysfunction. We are lucky because we live at the era of PD5. We have this medication for more than 15 years, and we have 4 potent selective PD5 inhibitors that they have approved by EMA but also by FDA. The efficacy of 4 PD5 inhibitors are almost in every subgroup of patients with erectile dysfunction has been established. So there is no a profile of patient that means that, okay, if you have diabetes mellitus, you go for this medication, if you have that, you go for that. Means that all pills are effective, independently of the cause of erectile dysfunction. And efficacy, we say it is effective. What is efficacy? Efficacy is defined as an erection with rigidity sufficient for satisfactory intercourse. Adverse events for all PD5 inhibitors are generally mild and self-limited. So in this table, there is a summarized, it is known of this 4 medication. It is important to know that sildenafil, vardenafil, and avanafil they do not go well with fatty meal, so the patient has to be with empty stomach. It's important, and also it is important to know the time frame that the pills are working. So let's keep in our mind that tadalafil needs a lot of time to start working. It has a lot of a big therapeutic window, and the other pills, avanafil is the more, and vardenafil are more fast. Avanafil has also a good window of acting, and also sildenafil, it's fast, but it has no so much window of acting. Regarding the adverse events are common. There is some more headache with vardenafil, and some more problems with dyspepsia with tadalafil. But all the other adverse events are similar. Tadalafil is the only pill that it is licensed for daily use for 2.5 and 5 millimeters. Actually, we use only the 5 milligrams per day, and this is the recommended dose. So this daily dosing provides an alternative for couples to prefer to have spontaneous rather than scheduled sexual activities, or who anticipate frequent sexual activity without scheduling the drug administration. For a lot of men, especially middle age, it is important to feel the freedom that they can have sexual activity without schedule of that. So taking the pill every day. give them more freedom for that. There is no clinical significance there is no significance of the efficacy if you take the pill daily or on demand. So sometimes continuous treatment may improve erectile function in men that they are poor responders to on-demand therapy, and I'll show later on that maybe we can combine the daily and the on-demand use. Of course, people with erectile dysfunction need for periodical reassessment because sometimes some factors that can be changed. So if for example, if somebody has diabetes mellitus and getting worse of erectile function and the pills do not work anymore, maybe the status of the diabetes, but the glucose is going up, so it needs reassessment. The only absolute contraindication of this medication is any form of organic nitrate, or of course organic nitrate or other NA donors, because if this combined, maybe we have a very decrease of blood pressure. All the other contraindications are relative. So if patient takes even antihypertensive drugs, usually the lower of the blood pressure is not significant, and sometimes we have consult the cardiologist or the internal medicine doctor and regulate the antihypertensive drugs in order to have properly the medication for ED. Concomitant treatment with alpha blockers may produce changes in hemodynamic parameters, but it does not increase the rate of adverse events or hypotension. It is common to combine PD-5 inhibitor daily, tadalafil, with, for example, tamsulosin for an alpha blocker, and maybe it doesn't give any additional benefit for the urinary function, but actually it is safe to do that. So, if everybody responds to the treatment, of course not. If everybody responds, we will be happy. So there are poor or non-responders. How we will manage them? It depends on the of identifying that if we can identify the underlying cause. We have to check the medication. Do they take the medication properly, with empty stomach, for example? What time frame they have before the medication? If they if they having interest of doing that, if they take a lot of excitement for sexual activity, and of course to check if the medication that they take is a licensed one, because on the internet a lot of people they buy whatever, and we don't know what exactly have all these pills. There are also studies regarding that they have proven that the medication through internet is not safe for this condition. Absorption of sildenafil, vardenafil, and sildenafil can be delayed with fatty meals. So we have to know the optimal time of administration for on-demand use. The patient education can help salvage, and upon if patient know, maybe he will return after education for non-responder to responder. And after emphasizing the importance of dose, timing, and sexual stimulation to the patient, erectile function can be effectively restored following the re-administration of this PD-5 inhibitor or maybe another one. So, hypogonadal patients not responding to PD-5s may improve their response to the treatment after initializing the testosterone therapy. This happens that if the testosterone is really low, maybe administration of the testosterone make the PD-5 to work better, because change the receptors. The better testosterone change the receptors. Some patients might respond better to PD-5 than to another, but there is a possibility of that, and so maybe we can switch from one medication to other, but we do not have so many data about that. Empirical, we do it, but it's not proven. That's why we do not have evidence for randomized controlled trials that they try to switch. In refractory, complex, or difficult to treat cases of erectile dysfunction, combination therapy should be considered as the first line approach. if somebody has a very severe erectile dysfunction, go directly for the best that we can in order not to get our patient very disappointed. Although the available data are still limited, combining PD5 inhibitors with antioxidants, with low intensity shockwave therapy or trick or vacuum erection device improves the efficacy outcomes without any significant increase of the adverse events. Additionally, the association to add on in the daily administration to add on a fast acting drug like as sildenafil or for on-demand use maybe also improve the erectile function. So it is another option of treatment of non-responders. Now we're moving for taking the Peros treatment to have a topical alprostate. We use a cream that includes a permeation enhancer to facilitate the alprostate absorption. So this cream is under the license of Vitaros. It is licensed at least in Europe. I don't know whether it is in the US. And with 3 milligrams. And we put in the meatus of the urethra. The truth is that some patients also put it inside and have some good results, but in patients with mild to severe, I think that more in patients with mild problems. Of course, if we put inside the meatus, they can increase the efficacy and the confidence among patients without increasing the adverse events. Of course, we can understand that performing something in the urethra has some limitations regarding the sexual activity. There is also another intraurethral administration. This is a pellet licensed under the name of News. In Europe, I don't think that it still exists. I don't know if it exists in the US. And also we have a lot of studies that they say that has an efficacy of about 30 to 60%, with the most common adverse events to be local pain, dizziness, and possibly hypotension because it's going intraurethral and maybe goes a systematic absorption of prostate. Actually, from this medication and this way of minimal invasive treatment, penile fibrosis and priapism are very rare. Urethral bleeding and urinary tract infections are related with the intraurethral use. The efficacy rates are significantly lower than for the intracavernous pharmacotherapy, and the adherence of the patients are about 30% for long term. So topical or intraurethral pharmacotherapy provides an alternative to intracavernous injection to patients who prefer a less invasive or low, although this is less effective treatment as well. So it is important at this point to consider also the psychological intervention and maybe therapy of the patient. This doesn't mean that the problem with the patient is psychological, because the patient said, "Hey, doctor, I don't go for psychiatric evaluation. I'm okay. I do not have nothing." But if we talk with him a lot, maybe he has anxiety, maybe he has issues with performance anxiety, and sometimes he will beneficial for cognitive behavioral therapy or whatever specific doctor or consultant can advise to him. CBT means cognitive behavioral therapy, is going to alternating dysfunctional cognitive and behavioral patterns influencing erectile function and decreasing adjustment during the course of the disorder. Sometimes maybe we need sexual skill training, or maybe we need marital therapy or psychosexual education. We have people that they do not respond to pills, but if you ask them a lot, you can understand that they are not happy with their marriage. So we cannot try to resolve this problem. This is not our job. We have to understand and to refer. About hormonal treatment. We had already a lecture about that. Okay, sometimes if there are also problems, if the testosterone is very low, and also we have symptoms of hypogonadism or have problems with sexual desire, maybe if make a replacement of testosterone, the sexual function will improve, or the patient will be responder to the pill. Moving forward to vacuum erection devices. These devices are working. The truth is that they are working in more than 90% of the patients. The overall satisfaction is from 30 to 90%, depends on the population and the setting of the studies. And the people that they use the devices, if they are okay, if they can use it and they are satisfactory, they continue to use it. If they do not use it, if they are satisfactory from the beginning, it is abandoned very, very early. So half of them, they stay on this treatment for about 2 years. Of course, after you maintain to achieve an erection with the vacuum device, to maintain it, you have to put the ring. So the ring has to be safe and removed in a time period in about 30 minutes in order to be sure that they will not have skin necrosis, etc. Of course, there is inability to ejaculate, there is petechia, bruising, and numbness as an adverse event, and the patient has to be informed that he has to remove in 30 minutes, and sometimes a lot of patients, they are complaining, and maybe the partners, they are complaining that the erection is cold. The penis is cold because it is no circulation of the bladder. I have a lot of experience with paraplegic with these devices, and it's important for people that they do not have good sensation to be very careful, because a lot of adverse events can be happening. Of course, if there are bleeding disorders or patients are in anticoagulant therapy, they cannot use this device. And maybe this device can be the treatment of choice in well-informed older patients with infrequent sexual intercourse and comorbidity requiring non-invasive drug-free management of erectile dysfunction. Sometimes we can use these devices not for sexual intercourse by itself, but for penile rehabilitation. For example, we use it after Peyronie's disease, after surgeries in the penis, in order to have better blood, after radical prostatectomy, to have better blood supply, not for intercourse, but wanting to imitate the spontaneous erections and to have better blood supply to the corpus cavernosum. And move to intracavernosous administration of vasoactive drugs. It is the oldest treatment that we have for erectile dysfunction. Can be offered injections, can be offered in every stage of the treatment workup. They have high efficacy, and the non-responders are 5 to 10%. Maybe a patient is on the pill treatment, and for some reasons wants to get an overperformance. He can try sometimes patients that they can try injections and pills depending on the status of the sexual activity that they have at that time. These are the scheme, the injections that we use. There are 3 drugs, 3 medications. There is the alprostadil, papaverine, and phentolamine. Actually, the license is only for alprostadil. The main adverse event of the alprostadil is the pain. Papaverine as a monotherapy has been abandoned due to high incidence of fibrosis. And phentolamine, if you use it alone, it's not very good. It's not very potent, and has some systematic cardiovascular problems. So that's why we use a little of phentolamine, using as base mix or as premix. So, but keep in mind that the only license is alprostadil, and regarding if we say the premix, in sometimes the premix that I perform with the premix that ASOP performs maybe is not the same, because it is not a drug that it is fixed by manufacturer, so it's something that we or our pharmacists put together according to our medication. So it is important if somebody is a responder or not, you have to tolerate the dose and to know that in every 3 mix or 5 mix he is using, he has the same concentration of the substitutes. Okay, now we're moving in something more new, more updated regarding innovative treatment modalities. These are two kinds of innovative treatment modalities. They are the regenerative medicine therapies, low intensity extracorporeal soft wave therapy, the PRP, platelet-rich plasma, the stem cells, and innovative, not regenerative, but innovative also some data regarding botulinum toxin. Let's see them one by one. So, regarding the shockwave, maybe under the theory, it is the only potential cure treatment for vasculogenic erectile dysfunction, because with this low intensity shockwave treatment, may we have new neoangiosis, new vascularity. But all the data that we have, they are not very persuasive and supportive, because there is a very huge heterogeneity in studies with different protocols, with different machines, different devices, and different patients. So, as years are coming, because we have this shockwave therapy for about 10 years, the studies now have to conclude some outcomes, and it seems that 0.1 microjoule per millimeter of square millimeter seems to perform slightly better than lower energies. So this energy maybe is a cutoff that when applied. In modest, we have the studies that improve erectile function, but the improvement appear to be modest. So the patient, they say that, okay, I have some better outcomes. On the other studies, there is a satisfactory rate between 30, 40, and 80%. We have also some limited data that there is an improvement in hemodynamic parameters after shockwave therapy, but we don't know if it is clinically significant, because we don't know what is the cutoff point of improving for having an outcome that it is directly compound with the erection. Of course, trying to resolve the problem of the patient, we use add-on treatment with PD5 non-responder. We use the shockwave therapy as an add-on treatment to non-responders to PD5, or we apply directly with shockwave therapy and daily PD5 inhibitor. The treatment effect 1 to 3 months after completion of the sessions, depending on the protocol that we use, and this beneficial outcome has a progressive decrease over time, but we have some data that they say that over the period of 5 years it still have some benefit. Better results could be achieved by combined with other treatment as vacuum device or tadalafil, especially some subgroups like the diabetes mellitus type 2. Now we'll move to PRP, to platelet-rich plasma injections. So intracavernous injections of PRP. There are several trials regarding this method. It's very innovative. PRP has been used almost in every part of the body as a potentially regenerative therapy. And we know that there are a lot of, during the platelets, inside the platelets, there are a lot of grave of growth factors like this one, and maybe there is a theory and there is a science behind that, that these factors can be responsible for angiogenesis stimulations and stem cells recruitment in the penis. So despite promising results, efficacy and safety, evidence is still insufficient to provide a recommendation regarding PRP in clinical practice, because there is high heterogeneity among studies regarding the timing and the dosing regimens, and there is no consensus regarding the optimal activation method and platelet concentration, and the need to measure quantitative and qualitative composition of growth factor and cytosines. That means that we inject something that maybe it's beneficial, but we don't know. We don't know what's the concentration of this, and this. So it has to do with the protocol that they use, and also with parameters of each individual patient. So it's not a method that it is standardized, and that's why we cannot have safe outcomes. So PRP should be used only in clinical trial setting, as larger trials are needed to confirm original findings and define the efficacy and safety. Moving to stem cells, the use of stem cell after regenerative treatment for it's a method that is under investigation. There was a systemic review some years ago, concluded that 5 completely human, it is a conclusion for in human trials. 5 trials have shown promise for stem cell therapy as a restorative treatment. But data are still insufficient to provide a clinical recommendation. It's the same problem with stem cells. We don't know exactly what stem cells we use and how we can use and activate them. But I think that's something that will continue to run. Now moving to botulinum toxin, the hypothesis behind botulinum toxin is that we know that botulinum toxin provides a relaxation to the muscles. And we also know that in the smooth muscles, like in bladder for example, can provide relaxation, and maybe under this was the hypothesis that the relaxation of the smooth muscles of the penis can improve the erection. So there are 2 randomized controlled trials. The first one with 70 patients refractory to PD5 received a single 100 units of botulinum toxin, Botox actually, or saline, it was controlled, and they continue to have the on-demand treatment of PD5 inhibitors. 53 of them, 53% of the active group, of the Botox group, reporting an erection hard enough for vaginal participation after 6 weeks. The other study is bigger, 176 patients, no responded to PDI or to 3 mg intravenousal. They have 3 groups, Botox 100, Botox 50 units or placebo, and 30% of both Botox arms responding satisfactory sexual activity at 3 months after treatment. In both trials, only mild local side effects, no systematic complication. And now I will transfer my personal way of thinking and experience, but at the end, sorry. There are other singular, not controlled studies that confirm these findings, showing a promising role for botulinum toxin in the treatment of patients who are non-responders, but of course no recommendation can be used in clinical practice because the data are limited. My personal thing, I have a lot of experience with Botox in neurogenic patients, so many injections, but we know that it's a toxin. And we know also that the penis is like a Venus, or like an artery, or like a Venus, depending on the status. So I am very skeptical of injecting the toxin in the penile. Of course, the data are there, so I think that in the future maybe we'll have something more regarding this. And actually, there is no other data that giving the botulinum toxin in the bladder, only the prostate, that may be beneficial for erection. We do not have something like that. Okay, I think that the future is here. What about herbal medicine and natural supplements? You know, natural supplements is very fashionable. Everybody wants to take something very potent but very healthy, okay? And it is a market that increasing the last years. But actually, there is no evidence that there is any something of that that really make a difference. But there is only ginseng may, in an Cochrane review, shows that ginseng have some moderate effects, and of course, in combination with PD-5 inhibitors, the addition of L-arginine maybe can improve sexual function. This is only from one study. All the other natural and herbal supplements, they are not having any evidence behind them. So coming to the end, we have the penile prosthesis. It is the surgical implantation of a penile prosthesis, may be considered in patients who are not suitable for different pharmacotherapies or prefer a definitive therapy or do not respond to other treatment modalities. Penile prosthesis have a very high satisfaction rate in patients, 90 to 100% depending on the studies, but also into the patient's partners. So the previous years we follow step-by-step treatment, first line, second line, third line. Now, in the era of well-informed patient and shared decision, maybe a patient, even he is responding, for example, to injections, maybe he, if he's well-informed, he wants to go directly to the prosthesis. So it means that it is not only a third line treatment. Sometimes the prosthesis come earlier, but of course with a very well-informed patient. There are two types of penile implants. There are inflatable, 2 or 3 pieces. Usually we use the three pieces. There are semi-rigid devices, malleable, mechanical, or soft flexible for some uses, and sometimes we can use the malleable for a short period and after pre-operation, for example, and after we change to the 3 pieces. There are 2 main surgical approaches, the penoscrotal and the infrapubic one. The last years, a lot of surgeons, they moved to the infrapubic, but okay, there is also the penoscrotal is also established, but also, and the main complication of the prosthesis is mechanical failure and infection. The mechanical failure, the last years, is less than 5% and has to do with the improvement of the devices and with careful surgical techniques, appropriate antibiotic prophylaxis, reduce infections to 2 to 3% in a primary implication of low-risk patients in high volume centers. So, and with the last, the very new the devices coated by antibiotics or with hydrophilic coated, maybe this complication rate is less in the right hands, in the right center, and in the right patient. Moving a little bit more about prosthesis. Of course, if patient has diabetes, if he's diabetic, or it has other comorbidities, or if it is a neurogenic one, the complication rate is increasing a lot, so we have to select carefully the patients. Okay, this is an algorithm from the European Association guidelines regarding all the procedure. It means that it's a step-by-step approach to provide, you see that this is in the same level, vacuum, cavernosal, oral, topical, intraurethral, and if we suppose that it is more vasculogenic, the origin go to low intensity, we reassess, psychological evaluation, go further, and maybe we go to the prosthesis. So coming to the end, Lifestyle changes can lead to erectile dysfunction improvement in specific populations. PD5 inhibitors are associated with significant improvement of erectile function with a good overall safety profile. There is no demonstrated differences among different PD5 inhibitors in terms of efficacy. Topical or intraurethral alprostadil is effective in improving erectile function, but data are still limited. Vacuum therapy can improve erectile function with a wide range of treatment satisfaction rate and some complications. Intracavernosus injection with alprostadil alone or in a premix setting is an effective treatment for erectile dysfunction. However, it has a relatively high treatment drop-off rate because it is invasive. Low-intensity shockwave therapy can a mild improvement of erectile function among patients with vasculogenic erectile dysfunction. Intracavernous injections of vasoactive drugs can lead to big improvement of function among patients with organic ED, but the available, this is for PRP. The intracavernous injection of PRP have led to mild improvement of erectile function, but the available evidence is still insufficient for provide a clear recommendation. Botulinum toxin has been shown an improved response rate to medical treatment for ED patients who were non-responsive to oral or intracavernous therapy, but the data are not so much. And penile prosthesis implantation is associated with high satisfaction rate among patients with erectile dysfunction. Thank you.
Thank you very much, Professor
I
Konstantinidis.
tried to provide an update because the topic is very huge.
Yes.
We could go deeply to surgical techniques about prosthesis, etc., but I don't think that it is the purpose of
Yes,
this.
you did a good job. This can be a whole day program.
Thank you very much. Now I invite Professor Indira for the following lecture on the strategies management of premature ejaculation.
Okay, are you still ready this late time? Let's see this nice again somewhere.
You cannot